Hey everyone, my name is Dr. Jory Fleischer, and I'm a movement disorders neurologist here at Rush. And I am honored to have the opportunity to speak to you today about PD 101 non-motor symptoms. So here's a quick overview of our slightly long and winding road, a couple of the things that we'll talk about today. So it's an ambitious agenda. We're going to try to tackle sialorrhea, which is a fancy word for drooling, dysphagia, which means trouble swallowing, weight loss, constipation, urinary dysfunction, sleep disorders, mood disorders, cognitive changes, and how to approach sudden changes versus gradual changes. So first, don't panic. Just because we talk about these things does not mean that all of these things happen to everyone. Everyone has some symptoms of Parkinson's disease, but no two people have the same exact combination. No one gets all of the things. So the reason that we talk about them and the reason that we have educational activities like this is to empower you as the person living with PD, as family members and caregivers supporting someone with PD, to know about these things. So if they happen, you know that they are treatable and manageable and we can do something about them. So let's get started. First, drooling. Not something people usually want to talk about. But here's the thing, drooling can be very common in Parkinson's. It can often start just with pooling of saliva on the pillow in the evenings and gradually become more present during the daytime. If this isn't bothersome, then we don't worry about it. We don't need to treat it. If it starts to become bothersome, an easy thing to do is actually to try something called a sialoga, which is a fancy word for something that actually stimulates more saliva production. Is that kind of counterintuitive? Yes. And the reason is that the reason people have extra saliva, that they have drooling in Parkinson's disease, is not actually because you're producing more saliva, but your brain isn't reminding you to swallow as much as you usually would. And so something that's sour, something in your mouth that's sour kind of reminds your brain that it needs to swallow. So sucking on a sour candy or chewing sugarless gum, things like that can really help. There are certain medications to help with drooling, but they tend to cause a lot of confusion and other side effects. So if we need something beyond sort of these non-medication options, we will often go to our most effective treatment, which is using botulinum toxin injections, or Botox for short, and we inject that in the parotid glands and the submandibular gland. It's usually 1 or 2 injections in each of these sites about every 3 months, and that can be really effective and very powerful to help someone with drooling. What about trouble swallowing or dysphagia? So see a specialist. Our speech and language pathologists are trained to evaluate and treat swallowing trouble. There are a lot of things that we can do. Why do we care about this? And why do we care about this in getting involved early? And I believe that you'll have a talk from Dr. Wong. So we know that there are many things that we can do. And if this isn't caught, if this isn't detected, people can have trouble with swallowing things down the wrong pipe. They can aspirate or cough food or liquids or particles of things into their lungs instead of down into the stomach. And that can lead to pneumonia and all kinds of complications. So while this gets more and more common as Parkinson's goes on, there are a lot of things we can do to treat it. What about unintentional weight loss? Not something that we think about all the time in Parkinson's, but it's actually very common as the disease goes on, especially in the later stages of Parkinson's disease. But in middle or early stage PD, there are a couple of things that we always want to make sure. Number one is that people with PD can still be affected by all kinds of other stuff that affects people, of that age. So age-appropriate screenings, meaning mammograms, colonoscopies, pap smears, all of these things, they're there for a reason. Is because at certain ages, people in those age groups are at higher risk of developing certain cancers or conditions. Stay on top of those age-appropriate screenings. Just because you have PD doesn't mean one of those other conditions can't be going on, and those can be common causes for weight loss. So while we can blame a lot on Parkinson's, we don't want to jump to Parkinson's as a cause of weight loss without doing some other investigations. If those have been ruled out, so dental evaluations and swallow evaluations are helpful. Oftentimes people with PD can have problems with their dentition. They can have early cavities, they can have very bad dry mouth, even with the drooling. They can have abscesses or tooth pain that can limit their intake of food, leading them to have weight loss. Sense of smell and taste can change. So someone may eat less just because things don't taste as good as they used to, in which case talking with a nutritionist, adjusting foods, adding seasoning can be really helpful. We also want to review medications to make sure you're not on something that could be accelerating weight loss. And then there are a lot of different things that we can do to try to prevent that unintentional weight loss. Because if someone is losing weight in Parkinson's without trying, it's not a good weight loss. It's actually losing muscle mass. And we want you to maintain that muscle mass because it helps keep your balance, protect you, prevent falls, cushion those hips so you don't have a hip fracture. And if we're talking about weight loss, it's hard to go too far without talking about constipation, so other bowel changes. So normally, food moves along in the gut and is processed, and the gut absorbs nutrients and water and everything that it needs and excretes stool. And the problem in Parkinson's disease is that that normal motion of the gut, it still absorbs everything it needs, it still absorbs water, but things move much more slowly. And the longer that food and material sits around in your gut is trained to keep absorbing stuff from it. So it absorbs more water. So you wind up having these very large, very dry, hard stools. And it's very hard for the gut to pass those along. And so people can get very constipated. And it's not that it happens over one day. Frequently it's happening over days, weeks, months. So it may not feel like a big change, but in fact, the gut changes early and quite significantly in Parkinson's disease. People can also have changes in the muscles that help you have a bowel movement. So some muscles need to relax, some muscles need to squeeze. And in Parkinson's disease, those messages are often crossed. And so people can strain and spend a lot of time trying unsuccessfully to have a bowel movement. But there are a number of things that can be done. So that slow transit, or the gut just moving slowly so things can kind of build up, and that sphincter dyssynergia, fancy word for the messages getting crossed with those muscles. With slow transit, we want to prevent constipation. And the best ways to do that are hydration, fiber, and exercise. All three, especially that triad altogether, that's really powerful. But if constipation is developed, we can treat it. And there are any number of recipes out there. I didn't create these, don't hold them against me, but they work. So mixing up equal parts bran, applesauce, and prune juice, or probiotic yogurts, bran, and fresh berries, which is getting you some fiber. So the theme being probiotics and fiber and bran can all really help. If we need to use medications or over-the-counter treatments, polyethylene glycol, which is often marketed as Miralax, tends to be one of our best options. You can be on it for long periods of time and your body doesn't develop a tolerance to it. Next, milk of magnesia, and we try to avoid some of these other things. So sphincter dyssynergia, that trouble having the bowel movement, physically getting the muscles to coordinate. So one thing that's been found is that if the person with Parkinson's is able to elevate their feet up onto a stool and change the angle of their hips just a little bit so that they're a little bit bent, almost in a squatting position, but still seated on the toilet, that can help get those muscles back in alignment. So that could take the shape of a stool that can fit underneath the toilet. You just want to make sure it has non-skid bottom so it's not a fall risk. Urinary dysfunction is very common in Parkinson's disease. And often this takes the form of people waking up at night and going to the bathroom frequently. And I always ask people, if we're going to try to target this, is it that your bladder is waking you up? Are you waking up because you have to urinate? Or are you waking up for some other reason and you might as well go because you're already awake? If it's the latter, then we want to figure out what's waking you up. But if it's the former, if it's really that you're waking up because you have to pee, then we have lots of different strategies that we can use. Sleep can be affected in any number of ways in Parkinson's disease. People can have trouble falling asleep, staying asleep. They can have sort of less restful sleep. They wake up still feeling tired. They can also have what's called REM behavior disorder, which is acting out your dreams during sleep. So you may have more vivid dreams, and maybe you weren't someone who previously remembered them, and now you do. And often these dreams are very active. You're being chased, or you're protecting your family, or there's something going on, something really intense. And the person who might be in the room with you knows that there's something going on that's pretty intense because they can see you kind of thrashing and kicking and fighting and maybe shouting and talking in your sleep. That's a classic symptom of Parkinson's disease. And if it's not bothering you, and if it's not bothering your bed partner, you don't have a bed partner to be bothered by it, we don't necessarily need to treat it. We treat REM behavior disorder if it's causing injuries, or if it's causing disturbances to sleep for you or your bed partner. For insomnia, we really want to look at all of the different things that could be contributing to trouble falling asleep, staying asleep, or waking up too early. And the list is lengthy. Especially important is sleep hygiene. So making sure that there is no TV in the room, that you're putting your phone down and you're not staring at a screen for at least a good amount of time before you get into bed, that the bedroom is really for sleep and your brain isn't associating it with eating, other activities, watching TV all night long, that you have a cool, dark environment to sleep in. And really simple things. So one of the main risks that people can have with REM behavior disorder is that if they're moving around during sleep, they might fling out of their bed and hit either their hand or their leg, or hopefully not their face, against a sharp nightstand. So cushioning the edges of anything sharp, ideally moving anything sharp way out of your way from where you're sleeping. Sometimes considering putting a very thin yoga mat just around the edge of the bed, not enough to trip on, but enough that if you fell out of bed, you'd land on something soft if you've got hardwood floors or harder floors. What about fatigue? So fatigue refers to this overwhelming sense of tiredness, low energy, or exhaustion despite restful and adequate sleep. There are things that we can try to do about fatigue, although it's still a pretty difficult symptom to treat in many cases. We really want to make sure that there is no depression, anxiety, or sleep disorders contributing, because those are big contributors and those are treatable. So don't be this guy. And like I said, depression is a big contributor. You saw it crop up in insomnia. We just saw it with fatigue. 30 to 40% of people with Parkinson's disease have depression. And this is not, well, you'd be sad too if someone told you you had Parkinson's. You're allowed to have that. This is depression that can come on any time before the diagnosis, often years before, and any time from the diagnosis afterwards. And it's related to chemical changes in the brain. It is the #1 predictor of quality of life in people with Parkinson's disease. Also, anxiety. So 40% of people with Parkinson's at some point will develop significant anxiety. This can be generalized, sort of just a more anxious sense all the time. This could be specific to certain situations, like, I don't know what traffic's going to be like. I don't know what parking's going to be like. The appointment is at 3 o'clock. It should take us an hour to get there. Let's leave at 11. We see this really commonly. It can also be related to medications wearing off, particularly if someone is on levodopa. Sometimes as the medication is wearing off and they're getting back to their own state, sort of their own low dopamine level, the anxiety may come up at that point. And as soon as the medicine kicks in, the anxiety gets better. It's really important to take note of the patterns of when anxiety crops up, what the situation is, because if it's related to medication timing, well, then we can adjust the medication timing. If it's related to certain situations, well, then we can take different approaches to address that. There are many different things that we can do to try to treat both depression and anxiety. So we have non-medication treatments, including supportive counseling, psychotherapy, cognitive behavioral therapy, and various different modes of support, whether that's any of our social support groups that Rush offers or many in the community. Exercise has been demonstrated repeatedly to help with depression and anxiety, relaxation, breathing, and mindfulness practices. And then we have many medication options to help us, where if those non-medication treatments are not sufficient, we can add on medication. I would just encourage you to remember that the depression is often related to chemical changes. And so the same way that we will address those chemical changes that affect movement with chemicals to restore that movement back to where you were before, we try to do the same with mood changes. It's trying to bring you back to who your baseline is, not to someone else. And it's important to remember that these symptoms didn't start overnight, and so treatments won't start overnight. They need time. Apathy occurs in about 17 to 70% of people, and it's really a lack of motivation. this often is not something that bothers the patient or the person with PD, but it bothers their family. So you've got this great schedule. The care partner says, you need to do physical therapy, you need to do this, you need to exercise, you need to take your meds on time, and the person with Parkinson's goes, yeah, not today, tomorrow. And separate from depression. It's really just almost like someone poked a hole in the gas tank of motivation. There is no magic medicine for this, but we treat the underlying problems, so cognitive issues and depression contribute, and we can treat those to some extent. And then having a daily schedule. I often describe this as a contract between the person with PD and their family. The family might want them to do 10 activities in the day. The person might want to do 1 activity that day, and maybe you agree to do 3, and you try to work up from there. There are a lot of different cognitive changes that can happen in someone with PD. So a fancy word, bradiphrenia, means a slowness of thinking, means the content is just fine. The person is thinking the right thoughts. They're getting to the same conclusions they otherwise would have. It just takes them a little bit longer. It takes a few extra clicks to get that thought in and get that thought out. And then as the disease progresses, sometimes we can see mild cognitive impairment or dementia. And the changes that happen in PD happen in specific areas of Parkinson's disease. So attention and working memory, executive function, language, memory, and visuospatial function. We'll talk about these. So by attention and working memory, I mean the person with PD may have decreased attention. They may have a harder time focusing on something. If they're interrupted, they may have a harder time getting back to it. They may have difficulty juggling multiple things in their memory. They may have trouble with multitasking, trouble with organization and planning of activities, difficulty switching their focus and switching tasks, and trouble initiating activities. Sometimes we can see decreased short-term memory, but long-term memory, things that happened years and years ago or in childhood, those don't tend to be affected. Knowing who someone is, knowing who family members are, that does not tend to be affected. But remembering what you had for breakfast this morning, that might be affected. People frequently complain of word finding difficulties or this tip of the tongue phenomenon where they go to say something, they know what they want to say. It's almost like that word is stuck in a file cabinet in their mind. They can picture it, they know it's there, they're rifling through the file cabinet, but they can't get to the word. And as soon as the conversation has moved on, they find that file, they find the word, they remember what they were thinking of. And this can happen with names, this can happen with words. This is common as people get older, just with normal aging, but it happens more so in Parkinson's as well. Also, visuospatial function can change. So what does this mean? Someone who has a good sense of direction at baseline, their sense of direction may change. They may find themselves getting more turned around in familiar or unfamiliar spaces. They may have difficulty navigating where previously they had a good sense of direction and they could find their way through things. They may misjudge distances and locations. So setting a plate right on the edge of the counter instead of setting it firmly on the counter and having things fall or having things go, not in a drawer that doesn't completely make sense, but maybe they put, their socks in the drawer next to socks, or maybe they put the dish away and, just they're slightly off. It's that visuospatial sense, sort of processing where things are in the world in relation to each other. That can be really affected in people with Parkinson's disease. So now let's talk about Parkinson's disease dementia. When we say dementia, dementia means a progressive decline in memory or thinking, at least one area of memory or thinking that is not reversible. It's progressive and continues to change over time. And it's enough to impact daily functioning. So in Parkinson's disease dementia, this is different from Alzheimer's. So in Parkinson's disease dementia, we see changes in attention, executive and visuospatial functions, much more so than memory. Sometimes we can see behavioral changes. We can also see hallucinations, apathy, as I mentioned, paranoia, or delusions. Really critically, we see fluctuations in the level of arousal and alertness that people have. What does that mean? Is one moment you are having a conversation with your loved one with PD, you're going back and forth, they're telling jokes. You could have a conversation and talk about their occupation or, hobbies and be really, really sharp. And 5 minutes later, it's almost like a fog has descended. Like they're in a cloud, they're in a daze, they have a glazed look. It's like someone just kind of turned down a dimmer switch. And there's nothing that clearly provoked it. And there's basically nothing you can do to kind of turn that dimmer switch back on until their brain does it on their own. And they will come right back, but it could be minutes, it could be hours. And as the disease progresses, the dimmer switch may turn down more frequently and stay down for longer, have these deeper, longer fluctuations as time goes on. Those fluctuations really distinguish PD dementia from Alzheimer's disease. Also visual hallucinations, depression, and some of those sleep disturbances, especially that REM behavior disorder, acting dreams out during sleep. The risk factors for PD dementia: older age, greater severity of motor symptoms, longer disease duration, and if someone has cognitive impairment or cognitive changes at the beginning of their Parkinson's, they're more likely to develop dementia. Finally, if someone has a stiffer, slower form of Parkinson's, less tremor dominant, then they're more likely to develop dementia. And finally, hallucinations. Visual hallucinations, seeing something that's not there, that's a risk factor for developing dementia. When we talk about delusions, what does that mean? So paranoia can be a generalized suspicion about something going on, or specific delusion. There's a specific delusion that can happen sometimes called delusional jealousy, which is where the person with PD believes, maybe not all the time, but they keep coming back to this belief that their loved one, their significant other, is cheating on them, even though that person may have been in the home with them throughout 24/7, 365 of COVID and never left their side. There's this deep-seated belief. Their brain is telling them that their significant other is cheating on them. That is not a reflection on the care partner. That is not a reflection on the person with PD. That is a reflection on this disease. Another common delusion is Capgras syndrome, or this belief that someone or something or some place is an imposter. That's not the real Mary. You look exactly like my wife, Mary. You sound exactly like her. You know things that only Mary could know, but I know that you're not the real Mary. When is the real Mary coming home? This is something that's been described in other conditions and previously was thought to be fairly rare in PD and PD dementia. But the more we ask about it, the more we learn that it's probably more common than we've given credit for. Sometimes our patients with PD say, I want to go home, and their loved one will reassure them, you are home. And they say, no, 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 take me home. And we often wonder whether they're, sensing that their home is not quite right. There's something that their brain is telling them is not quite right. So hallucinations are a false or distorted sensory experience that appears real, but is generated by the mind. And this could be visual, this could be less likely heard, felt, or even smelled or tasted. And the numbers of how many people with PD develop hallucinations varies depending on the study. This can often be caused or made worse by PD medications. So if hallucinations start, we will really review those medications to make sure that it's not medication related. There are various different types of hallucinations. So people can have illusions where they mistake something that's actually there to be something else. So that chair in the corner, I thought that chair was a person, but I turned and looked and it's a chair, versus a hallucination where there is nothing, but the person sees something most likely or senses in a different way. These can be flashes of light, flashes of color, and they can evolve over time to take on shapes like animals, often beloved pets from the past, or people, groups of people. Typically, the person knows that these are not real, at least at the beginning, but over time they may become more complicated and the person may have less insight into these hallucinations. So, all of that being said, take a breath and remember that we're here because there's so much that we can do about this. Right? So I said we want to empower you to recognize these symptoms so that if they happen, you know what to do, right? So sudden versus gradual changes. Any sudden change, we want to exclude another cause of altered mental status, delirium, confusion, depression. Urinary tract infections are so common and so commonly will cause sudden changes in the person with PD. And they don't show up the way that urinary tract infections are supposed to. They don't necessarily cause more frequent urination or cause a change in the color or the smell of your urine. They cause sudden hallucinations or sudden worsening of the person's walking or sudden falls out of nowhere. Other causes are other infections. So COVID-19, really, please get your vaccinations. They are safe and highly recommended for people with Parkinson's disease. Really. Pneumonia, other infections, constipation, bowel obstructions, recent medication changes, any recent medication refills where the pill has changed color or shape or size. We want to make sure that it isn't something different. Cough and cold medications, sleeping pills, and pain medications can cause sudden changes. And so we always review any new medications and wean off those that could worsen memory or thinking. When changes are gradual, we want to simplify the medication regimen as time goes on, as much as we can, to try to balance motor and cognitive problems. It's really important to know that levodopa or carbidopa-levodopa or Sinemet is the least likely of our motor movement medications to provoke cognitive changes, hallucinations, or delusions. It's the last to go. We want to maintain a structured and familiar environment, an individualized daily schedule, and often cognitive rehabilitation therapy by a speech language pathologist or an occupational therapist can be very helpful. We do have medications as needed to treat cognition, so memory and thinking. These medications don't necessarily cause an obvious improvement. What they've been shown to do in clinical studies is to slow how quickly things are getting worse. Do we wish we had something better? Absolutely. Are there studies underway to find something better? Yes. But in the meantime, these medicines have been studied and found to be helpful in people with PD. We just have to know what to expect from them. We have medications to help treat psychosis, meaning the hallucinations and the delusions, if they are bothersome. So first we reduce unnecessary medications, and then we can use antipsychotics. And the class of antipsychotics, there are a lot of different medications there. Some are better than others. So talk with your doctor about different options if we need to use those. And with that, I thank you so much for your time. I know that's a lot of information. Hopefully the slides are with you. You can reference them at any time. And thank you so much for showing up for yourself and your loved ones to learn more. Have a great day.